Hello everybody and welcome to our module on the pituitary gland. The pituitary gland is sometimes called the master gland because it exerts control over other endocrine organs. It's an endocrine gland that sits at the base of the brain. It sits in a small cavity of the sphenoid bone of the skull called the sella turcica. This is a picture on the screen showing where the pituitary gland sits. It's shown in red in the middle of the picture. It has an anterior and a posterior lobe, each of which have different functions. Also note that the optic chiasm is just above the pituitary gland. That'll be very important later when we talk about ocular findings associated with enlargement of the pituitary gland. The pituitary gland is connected to the hypothalamus via a structure called the pituitary stalk. Specifically, it connects to the median eminence of the hypothalamus. This is one of the circumventricular organs, or CVOs, that do not contain the blood-brain barrier, and I talk about these in more detail in the neurology modules. The posterior pituitary gland is also called the neurohypophysis, and it secretes two hormones. The first hormone is ADH, or antidiuretic hormone. It's also sometimes called vasopressin. And the second hormone is oxytocin, which is important during pregnancy. The posterior pituitary is derived from neural ectoderm in the floor of the forebrain. In other words, it grows out of the brain. It contains axons and nerve terminals. The neurons originate in the hypothalamus, and they extend their axons and nerve terminals down into the posterior pituitary. You can basically think of the posterior pituitary as a giant nerve ending that releases substances into the blood. The substances are the two hormones ADH and oxytocin. They are synthesized in the hypothalamus and then transferred down to the nerve endings in the posterior pituitary, from which they are released into the bloodstream. There are two types of neurons in the hypothalamus that make the hormones of the posterior pituitary. They are called the paraventricular and the supraoptic nuclei. The paraventricular nuclei make oxytocin, and the supraoptic nuclei make antidiuretic hormone. The anterior pituitary gland is called the adenohypophysis. It is derived from an embryonic structure called Rathke's pouch, which is an outgrowth of the oral cavity. So this portion of the pituitary gland comes from the mouth, as opposed to the posterior pituitary, which comes from the brain. And the anterior pituitary gland contains 5 cell types that make hormones. There are cells called corticotrophs, which make ACTH. There are thyrotrophs, which make TSH. Then there are the gonadotrophs, which make the reproductive hormones LH and FSH. Then there are somatotropes, which make growth hormone. And finally, there are lactotrophs, which make prolactin. There is a blood supply that connects the hypothalamus to the anterior pituitary gland called the hypothalamic portal system. This is the main blood supply of the anterior pituitary gland, and it delivers releasing and inhibitory hormones directly from the hypothalamus to the anterior pituitary. So for example, there is a hypothalamic hormone called CRH, or corticotropin releasing hormone, which will go through the portal system to the pituitary and stimulate the release of ACTH. In the same manner, the hypothalamus can release TRH, GnRH, or GHRH to drive the release of TSH, LHFSH, and growth hormone. Prolactin is unusual. It is released from the pituitary and it's controlled by dopamine from the hypothalamus, but dopamine inhibits prolactin release. Also along those lines, somatostatin can be released by the hypothalamus and it inhibits release of growth hormone and TSH. So we'll begin our discussion of pituitary hormones by talking about prolactin. Prolactin is a protein hormone and it regulates milk production in mothers. As I mentioned to you before, prolactin is under inhibitory control from the hypothalamus. The hypothalamus releases dopamine, which inhibits the lactotrophs in the anterior pituitary gland that produce prolactin. It does this by binding to D2 receptors. What this means is that if you destroy your hypothalamus, you will see a rise in prolactin levels, and this is relatively unusual. For most of the other anterior pituitary hormones, destruction of the hypothalamus leads to a fall in hormone levels. This is not true for prolactin because it's under inhibitory control. Prolactin can exert feedback on the hypothalamus. It can increase the dopamine release, and this leads to a fall in the prolactin level. You should know that there are many other substances which have been shown to affect prolactin release. These include VIP, oxytocin, TRH, and many other hormones. If you do a PubMed search on hormones and prolactin release, you will find lots and lots of papers. One that is worth knowing about for step 1 and clinically is TRH, or thyrotropin releasing hormone. This is the hormone that stimulates the release of TSH from the anterior pituitary. And this hormone level is elevated in hypothyroidism. When the level of thyroid hormone is low, it stimulates the hypothalamus to release TRH, and TRH can stimulate the release of prolactin. That means that hypothyroidism can predispose patients to develop hyperprolactinemia. And in fact, hypothyroidism is in the differential diagnosis for pituitary enlargement and hyperprolactinemia, and that's because of the effect of TRH on prolactin release. Prolactin is very important during pregnancy. During pregnancy, estrogen levels are high, and estrogen can stimulate prolactin release from the pituitary gland. It can stimulate gene transcription for prolactin. It can also stimulate the release of the hormone from lactotrophs. For this reason, there's a marked increase in the number of lactotrophs in the anterior pituitary gland during pregnancy. This means that the pituitary gland will grow in size during pregnancy. Prolactin is also important during pregnancy because it inhibits the release of GnRH from the hypothalamus. GnRH is the hormone from the hypothalamus that drives the release of the reproductive hormones LH and FSH from the pituitary. So when GnRH release is inhibited by prolactin, this results in cessation of ovulation and menstruation, which is something you want to have happen during pregnancy. Prolactin is very important in pregnancy for preparing the mammary glands to produce milk. Prolactin stimulates growth of the mammary glands when the woman is pregnant. Importantly, milk production in pregnancy does not occur, and that's because estradiol and progesterone levels, which are very high during pregnancy, block prolactin effect on milk production. After childbirth, however, the levels of estradiol and progesterone fall, and then milk production occurs from the mammary glands, which have grown in size because of exposure to prolactin. Now that we understand the physiology of prolactin secretion, let's talk about some clinical correlations of that physiology. And the first clinical correlation is a group of drugs that function as dopamine agonists. These are drugs like cabergoline and bromocriptine, and these can be used to treat Parkinson's disease. Parkinson's disease results from low dopamine activity in the brain, so it makes sense to treat it with a dopamine agonist. You can also use dopamine agonists to treat prolactinomas because they function like dopamine and therefore they shut down prolactin release. So when you use these drugs, whether it's for Parkinson's or to treat a prolactinoma, you will see an inhibition of prolactin release via binding to the D2 receptors. One of the most important clinical correlations of prolactin physiology has to do with pituitary adenomas. These are tumors that can develop in the pituitary gland, and they can be of any cell type in the anterior pituitary, and some of them result in increased secretion of hormones, and the type of hormone depends on which cell type has caused the adenoma. But you should know that the most common hormone-secreting tumor of the pituitary gland is a prolactinoma, and we'll talk in a minute about what that means in terms of symptoms. If you look at this chart on the screen, I've shown you what can happen if you get an adenoma from the different cell types in the anterior pituitary. So an adenoma of lactotrophs leads to hyperprolactinemia. An adenoma of thyrotrophs leads to central hyperthyroidism. An adenoma of corticotrophs leads to Cushing's disease. Remember that Cushing's syndrome is a syndrome of excess cortisol. Cushing's disease is a pituitary tumor causing Cushing's syndrome, and that tumor comes from an adenoma of the corticotrophs. And then finally, if the somatotrophs develop into an adenoma, that will produce an excess of growth hormone, which leads to acromegaly and gigantism, which we'll talk about later. No matter which cell type causes the pituitary adenoma, there are some general symptoms that can occur when the pituitary gland becomes enlarged. The first symptom is headache, and the second symptom is a special type of visual loss called bitemporal hemianopsia. If you look at this picture on the bottom right side of the screen, you can see that this person is unable to see in the outer portions of both visual fields. Those portions of the visual fields are near the temples, hence this is called bitemporal hemianopsia, and pituitary adenomas are a classic cause of bitemporal hemianopsia. This is the way it's often drawn in a schematic to show you the black portions are where the patient can't see. I have always remembered that pituitary adenomas cause this because I have just thought of an enlarged tumor pushing the black portions to the outside, causing the visual loss. And the reason this pattern of visual loss occurs is because there is compression of the optic chiasm, which, as I showed you before, sits right on top of the pituitary gland. Now let's get back to talking about pituitary adenomas that secrete prolactin, which are the most common type. Those pituitary adenomas cause hyperprolactinemia, and the symptoms of high prolactin levels vary by whether you're a man or a woman. So in women, this causes amenorrhea. Remember that prolactin suppresses GnRH, and this suppresses LH and FSH, and thus the menstrual cycle does not occur. In addition, women can develop galactorrhea, and this is because the prolactin drives growth of the mammary glands. In men, they develop what's called hypogonadic hypogonadism. This means that the LH and FSH levels are low, and thus they develop decreased libido, impotence, infertility, and sometimes they can develop gynecomastia. There's usually no galactorrhea in men, and that's because they don't have enough breast tissue present for the mammary glands to grow. Here's a summary of prolactinomas highlighting some of the points I made on the last few slides. It's the most common hormone-secreting tumor of the pituitary gland. It results in headache and visual loss. Rarely it can cause seizures. In women, it can cause amenorrhea. It also sometimes causes fractures. This is from low bone density, from low levels of estrogen. In men, it can cause loss of libido and impotence. The diagnosis is made by measuring the serum prolactin level and then doing CNS imaging to identify the tumor. And you can treat it with those dopamine agonists we discussed, like bromocriptine and cabergoline. These will shrink the size of the prolactinoma. Now let's talk about another clinical correlation of prolactin physiology, and that has to do with drugs that function as dopamine antagonists. There are many drugs which are dopamine blockers. Many antipsychotics like haloperidol and risperidone block dopamine receptors. There is an antiemetic that's sometimes used for vomiting called metoclopramide, which also blocks dopamine. And blockade of the D2 receptors can lead to high prolactin levels, and high prolactin levels are responsible for some of the side effects of these drugs. So people taking these drugs can experience amenorrhea, breast engorgement, galactorrhea, or sexual dysfunction. These are all related to the high prolactin levels, which you should now understand. In addition, many of these drugs cause Parkinsonian symptoms, which are movement symptoms similar to Parkinson's disease. And that's because blocking dopamine receptors in the central nervous system results in a relative deficiency of dopamine activity, and that's the same mechanism by which Parkinson's disease occurs. Moving on, now let's talk about hypopituitarism, which is underfunction of the pituitary gland. This can be caused by anything that damages the anterior pituitary gland. This can be a mass if you have a non-functional adenoma of the pituitary gland, which is an adenoma that is not producing hormones. It can grow in size and compress the functional cells of the pituitary and cause hypopituitarism. There's also a tumor called a craniopharyngioma, which we'll talk about in a minute, that can affect the pituitary gland. And then the other usual things can damage the pituitary, like ischemia, brain injury, or hemorrhage. When you have damage to the pituitary gland, you have deficiency of all the pituitary hormones, but one of the ones that's most important is ACTH. Recall that ACTH drives the adrenal gland to produce cortisol, so when you are deficient in ACTH, you will have a low cortisol level, and that can present as shock and hypotension. Importantly, patients with hypopituitarism do not lose aldosterone. That's because aldosterone is controlled by the renin-angiotensin system, so you don't see salt wasting in hypopituitarism. You also don't see hyperpigmentation. In the adrenal modules, I talk about how you can get hyperpigmentation when the ACTH level is high in primary adrenal disease. You do not have primary adrenal failure. In this case, the ACTH level is low, and therefore there's no hyperpigmentation. And then you can also see deficiency of the other pituitary hormones. TSH can be deficient, and that can lead to hypothyroidism. LH and FSH can be deficient, and that can lead to hypogonadism. Craniopharyngioma is a benign tumor that occurs in children 10 to 14 years old, and it's derived from Rathke's pouch, that embryologic structure that grows from the mouth. And this is one of the most important things you need to know for step 1. The symptoms are from compression of other structures by the tumor, so you can see hypopituitarism from compressing the pituitary gland. There can be a headache and visual field defects, as we talked about before, and sometimes these children have behavioral changes from frontal lobe dysfunction. Another cause of hypopituitarism is called the empty sella syndrome. In this syndrome, there is an enlarged sella turcica seen on imaging that is partially filled with CSF. It's called empty because the CSF appears clear on imaging, and thus the sella turcica looks empty. Rarely, the CSF can compress the pituitary gland and cause hypopituitarism. This is a very rare syndrome, but it's more common in women who are obese and have hypertension. Radiation therapy is a well-described cause of hypopituitarism. Some head and neck tumors are treated with radiation, especially brain tumors and nasopharyngeal carcinomas, and some pituitary adenomas are also treated with radiation, and the radiation can damage either the hypothalamus or the pituitary, and via damage to either of these structures you can potentially develop hypopituitarism. Pituitary apoplexy is a sudden hemorrhage into the pituitary gland. This is a sudden onset of hypopituitarism. It often occurs due to hemorrhage into a pre-existing pituitary adenoma. There are also often risk factors for bleeding present. For example, the patient may be taking blood thinners like warfarin. It will present with the sudden onset of a headache and diplopia from compression of the oculomotor nerves, and then there will be signs and symptoms of hypopituitarism. What usually dominates the clinical picture is shock from loss of cortisol. Sheehan syndrome is a form of hypopituitarism that occurs after childbirth. Remember that the pituitary gland becomes enlarged in pregnancy due to increased production of prolactin. The blood supply, however, stays the same. This leaves the pituitary gland vulnerable to infarction from hypovolemic shock. So if a woman suffers postpartum hemorrhage and hypotension, she can damage her pituitary gland and develop hypopituitarism. If this is severe, it can present as shock after delivery from low cortisol levels. If it's not severe, it may present as a failure to lactate from loss of prolactin. Just a quick slide on the treatment of hypopituitarism. The treatment is to supplement the missing steroids. So you can give corticosteroids to people who have low cortisol levels, such as women who have shock from Sheehan syndrome. You can supplement thyroid hormone, growth hormone, and estrogen or testosterone, depending on which hormone level is deficient. Moving on, now we'll talk about growth hormone, which is another anterior pituitary hormone. It's also called somatotropin. It is a protein hormone, and it's important for linear growth in childhood, especially for height and growth of the arms and the legs. It's released in a pulsatile manner, which is relatively unique. Between pulses, the level may become undetectable, and we'll talk later about how this has some important clinical indications for monitoring patients with growth hormone deficiency or excess. Just like prolactin, there are many stimulants and suppressors of growth hormone that have been described. Some that are worth knowing about include that the pituitary release of growth hormone is stimulated by GHRH, which is the hormone that comes from the hypothalamus, also exercise and sleep. In fact, levels of growth hormone are very high just after the onset of sleep. And the easy way to remember these two things is to remember that if you want children to grow up, they need to get lots of exercise and sleep. There are many reasons for this, but one of them is so that their levels of growth hormone remain high. The release of growth hormone is inhibited by several things that are worth knowing. One of them is high glucose levels, another is the hormone somatostatin, and another is the hormone insulin-like growth factor 1 or IGF-1. We will talk about both of these in the next few slides, but they are part of the feedback mechanism by which levels of growth hormone are controlled. Growth hormone has a receptor that has been well described in the basic science literature. It's a membrane-bound receptor, and you should know that it's a membrane-bound receptor because growth hormone is a protein hormone, and almost all protein hormones have a membrane-bound receptor. When that receptor is activated, it activates an enzyme called Janus kinase 2 or JAK2, which is a cytoplasmic tyrosine kinase enzyme. This enzyme will phosphorylate tyrosine residues within the JAK2 enzyme and also on the growth hormone receptor. This forms binding sites for many signaling molecules, and this leads to alteration of gene expression. The liver contains many growth hormone receptors. When growth hormone goes to the liver and binds its receptors, it stimulates the release of another hormone called IGF-1. IGF-1 stands for insulin-like growth factor 1. It's also called somatomedin, and it's a hormone that's released into the blood by the liver that mediates many of growth hormone's effects. And this is important clinically because you can measure the serum level of IGF-1 as an indicator of growth hormone function. Remember what I told you before, growth hormone is released in a pulsatile manner, so its level goes up and down. A single blood test is not very helpful, so instead you can measure the level of IGF-1 and it tells you what's happening with growth hormone production from the pituitary. IGF-1 is also produced outside the liver in many peripheral tissues and it exerts lots of effects on nearby cells via a paracrine mechanism. So now let's talk about the effect of growth hormone on cells and tissues, and I'll begin by discussing the direct effects. These are effects due to growth hormone itself, not mediated through IGF-1. Growth hormone can decrease glucose uptake by cells. It is anti-insulin. It will raise the blood sugar. It's sometimes called diabetogenic. Peripheral tissues exposed to growth hormone become insulin resistant. As a result, insulin levels need to rise in order to maintain the blood sugar, and therefore patients develop hyperinsulinemia when growth hormone levels are high. An easy way to remember the effects on blood glucose of a number of different hormones is to remember those hormones that oppose insulin. So you know that glucagon opposes insulin, but so does cortisol and epinephrine, and so does growth hormone. So in the setting of excess levels of all of these hormones, insulin levels need to rise because these hormones are opposing insulin's effect. This means the patient will develop hyperinsulinemia, and potentially the blood sugar can begin to rise and the patient can develop diabetes. Another direct effect of growth hormone is to promote lipolysis. It can activate hormone-sensitive lipase, and then as we saw before, growth hormone stimulates the production of IGF-1 from the liver. Indirect effects that are mediated via IGF-1 include stimulation of chondrocytes. The chondrocytes are the important cells for bone growth, so when these are stimulated, especially in children, this will lead to increased linear growth of bones. IGF-1 also stimulates muscle cells, so you get an increase in lean muscle mass as a result of growth hormone. And IGF-1 can also stimulate various different organs so that you can get an increase in organ size. Here's a summary slide of the control systems for growth hormone and its effects. GHRH from the hypothalamus stimulates growth hormone release. Growth hormone can directly affect glucose by opposing insulin and raising the blood sugar. It can also directly lead to an increased lipolysis in adipose tissue. And then finally, it can stimulate IGF-1 to be produced by the liver. Via IGF-1, growth hormone can produce changes in bones and muscles. It can drive linear growth of bones and the production of lean muscle mass. IGF-1 and glucose can negatively feed back to decrease the amount of growth hormone. In addition, IGF-1 and glucose can drive production of somatostatin from the hypothalamus, which also inhibits the production of growth hormone. The effects of growth hormone deficiency depend on whether you are a child or an adult. In a child, this leads to failure to grow. In an adult, this leads to increased fat, decreased lean body mass, and low energy. Growth hormone deficiency is most commonly caused by a pituitary tumor. It can be a mass effect from a non-hormone secreting pituitary tumor, or sometimes it's a consequence of surgery or radiation to treat a pituitary tumor. The treatment is to administer synthetic growth hormone, and you can monitor the effect of the growth hormone you're giving by measuring the serum IGF level. Remember, that is used to monitor whether the patient has enough growth hormone in their body. Growth hormone excess is most commonly caused by a pituitary adenoma of the somatotrophs that produce growth hormone. This will lead to a high level of growth hormone and IGF-1. The level of GHRH coming from the hypothalamus will be low. The hypothalamus is trying to shut down production of growth hormone, but the adenoma is not responding. In addition, the somatostatin coming from the hypothalamus will also be high, trying to shut down production of growth hormone. And this can present with headache and vision loss, many of those symptoms we described before from enlargement of the pituitary gland. More rarely, growth hormone excess can occur from GHRH secreting tumors. Hypothalamic tumors sometimes do this, carcinoid tumors sometimes do this, rarely small cell lung cancer can do this. In these cases, the GHRH level will be high. It is driving production from the pituitary of growth hormone. Children who have growth hormone excess become enormous. They have excessive growth, and this is called gigantism. Importantly, they have excessive linear growth, especially of their bones, so this will result in a very tall child. On the right side of the screen is a height and weight chart like you will use on your pediatric rotations. Each time the child presents, you'll measure the height and weight and plot it with a little dot. If they are in the middle of these lines, they are at the 50th percentile for children in their age group. A child who suffers from growth hormone excess will be enormous. They will have lines that are way up here, indicating that they are far outside the norm for their age from gigantism. Adults, on the other hand, who develop growth hormone excess get a characteristic clinical syndrome called acromegaly. Acromegaly is very rare and it's difficult to diagnose because it has a very slow, insidious onset. The average duration from symptoms to diagnosis is 12 years. One of the characteristic features is an enlarged jaw. The growth hormone drives changes in the bones of the face. In addition, there will be coarse facial features like enlargement of the nose and the frontal bones. Shown on the screen here is a classic picture of a man who has acromegaly. You can see that he has this square jaw and this very bony face that is somewhat large, and that is typical of people who develop acromegaly. Another characteristic finding is in the hands and the feet. The hands and feet get very large. If you look at this picture on the screen, on the left is a normal hand, on the right is a man with acromegaly. You can see that the hand is much bigger. A classic complaint from the patient is to say that their glove or shoe size has been increasing even though they are already fully grown. Another classic complaint are rings that no longer fit on their fingers. Another problem that occurs in patients with acromegaly is diabetes. As we talked about before, growth hormone is anti-insulin. This causes insulin resistance, and as a result, the insulin level has to rise to control the blood sugar. In some patients, the insulin is not able to rise enough to keep the blood sugar normal, and thus diabetes develops. Diabetes occurs in about 10 to 15% of patients with acromegaly, and 50% of patients have an abnormal glucose tolerance test. Other findings of acromegaly include visceral organ enlargement. The thyroid, heart, liver, lungs, kidneys, and prostate can all grow in size from growth hormone. There is enlargement of the synovial tissue and cartilage in joints. This leads to joint pain, which is a major problem in people with acromegaly, especially in the knees, ankles, hips, and spine. A common presenting complaint is joint pain, and then on physical exam, the facial features are abnormal and the hands and feet are enlarged. And then finally, patients with acromegaly can develop cardiovascular disease. They have an increased incidence of hypertension, left ventricular hypertrophy, and cardiomyopathy, and mortality is increased among patients with acromegaly due to higher rates of cardiovascular disease. There are a number of tests that can be used to diagnose growth hormone excess. One is to measure the level of serum IGF-1. As we have discussed before, the IGF-1 level is constant in contrast to the fluctuating levels of growth hormone. Therefore, IGF-1 is a good marker of growth hormone levels. You can also do an oral glucose tolerance test. You administer glucose to the patient. Recall that glucose should suppress growth hormone levels. In normal subjects, the growth hormone level falls within 2 hours. In patients who have high levels of growth hormone in their body, their post-glucose level will be high. And then finally, CNS imaging, especially MRI, is often necessary to look for the pituitary adenoma. You can treat growth hormone excess with octreotide. Octreotide is an analog of somatostatin, and somatostatin is the hormone that the hypothalamus releases to shut down growth hormone production by the pituitary. So if you administer octreotide, it will suppress release of growth hormone from many pituitary adenomas. Surgery and radiation are also often required, and the goal of therapy is to lower the IGF-1 level to within the reference range. Once again, IGF-1 is used as a marker of growth hormone production. Unfortunately, the bony changes usually do not regress. Tall children remain tall and big hands stay big, and in adults who have acromegaly, the joint symptoms often continue and develop into a chronic problem. I'll finish this module by discussing a couple of other hormones produced by the pituitary gland. The first one is MSH, which is melanocyte stimulating hormone. This is a hormone that can stimulate melanocytes in the skin. That's how it gets its name. There is a prohormone produced by the pituitary gland called pro-opiomelanocortin. It is a precursor of ACTH, which stimulates cortisol production from the adrenal glands. It is also a precursor of several forms of MSH. If you look at this picture at the bottom of the screen, POMC is formed and it is split into ACTH as well as several forms of MSH. The MSH can stimulate melanocytes to produce melanin, and this can darken the skin. And this is important in Cushing's disease. When you have an ACTH producing adenoma of the pituitary gland, you will also get excess production of MSH, and this will cause hyperpigmentation. This is seen in Cushing's disease, which is different from Cushing's syndrome. Cushing's syndrome means high levels of cortisol coming from the adrenal gland, not driven by ACTH. Cushing's disease is high levels of cortisol driven by the pituitary gland. That is caused by high levels of ACTH, and in Cushing's disease you also see hyperpigmentation, and that is because of MSH. We mentioned oxytocin before. It is produced by the paraventricular nuclei of the hypothalamus. From there it's transferred to the posterior pituitary where it's released into the bloodstream. Oxytocin causes milk release in response to suckling of babies. When the baby suckles on the mother's nipple, afferent fibers from the nipple go to the spinal cord. That triggers the release of oxytocin from the posterior pituitary, and then oxytocin triggers contraction of myoepithelial cells in the breast, and this helps the baby to get more milk. Oxytocin also causes contraction of the uterus. Oxytocin receptors upregulate in the uterus when the baby gets near term, and this is going to be important when you do your OBGYN rotations because you will administer a drug called Pitocin, which is synthetic oxytocin. This is used for induction of labor. It's also used in women who have heavy uterine bleeding postpartum because it will contract the uterus and limit the amount of bleeding.
Finally, I'll discuss somatostatin. Somatostatin inhibits the release of many other hormones. I talked about somatostatin in the GI modules because it's released by D cells throughout the GI tract. It's also found in nerves throughout the entire body. It was originally discovered in the hypothalamus where it inhibits growth hormone release from the pituitary as we have been discussing in this module. The place where you will most often encounter somatostatin clinically is when it's used as a drug called octreotide, which is an analog of somatostatin. And this drug can be used in acromegaly, as we have discussed. It can also be used in carcinoid syndrome and in glucagonomas and insulinomas. In all of these situations, it's being used to suppress hormone or neurotransmitter production by tumors. In addition, it can be used in upper GI bleeding. This is for a different reason. It's useful here because it's been shown to decrease splanchnic blood flow, and this can limit the amount of upper GI bleeding. And that concludes our module on the pituitary gland.